Scott. There we go. Thank you.
Yes.
Excellent.
Okay, we're gonna start. I want to welcome everyone. We are thrilled to have you join us today for this insightful discussion on virtual reality. My name is Fuad Munzer, a clinical psychologist and a fellow VR enthusiast. Today, we have the privilege of learning from a true pioneer in the field of VR therapy for anxiety disorder, Dr. Elizabeth McMahon. Dr. McMahon is a renowned clinical psychologist with over 40 years of experience specializing in anxiety treatment. But her expertise doesn't stop there. She's been at the forefront of VR therapy since 2010, actively using it to help clients overcome their anxiety. Dr. McMahon's knowledge extends far beyond the treatment room. She is a prolific author, having written a self-help guide for overcoming anxiety, a therapist manual specifically on VR therapy for anxiety, book chapters, and contributing to papers on the subject. She's also passionate about sharing her knowledge and actively training therapists around the world on using virtual reality to combat anxiety disorder. Throughout this webinar, Dr. McMahon will be sharing her invaluable insights on using virtual reality in therapy, why, when, and how. Get ready to delve into the exciting possibilities of VR exposure therapy, explore how it integrates with cognitive behavioral therapy, and gain practical knowledge you can potentially apply in your practice. So without further ado, let's welcome Dr. Elizabeth McMahon.
Thank you so very much. It's an honor to be here, a privilege. I'm very, very excited. I'm so proud of everyone who's here for your interest in this and your commitment to really offering the best treatments to your patients. So we will have 2 quick breaks, and there will be time for questions and answers afterwards. At the end, if you want to put questions in the chat, I can go back and review them. And let's get started. Let's not wait. So why, when, and how would you offer virtual reality? Why would you use VR as a tool in your practice? Let me give you a little bit about my background. You know, I have written, as was mentioned, several books, 2 of them specifically on the topic of anxiety and its treatment. The Overcoming Anxiety and Panic Interactive Guide is the self-help book for clients, for patients. And the VR reality, the virtual reality therapy for anxiety is the guide for therapists. I got my master's and my PhD from the Case Western University, and then did both a pre-doctoral internship and then a postdoctoral residency, so that I've been training and teaching and seeing patients, as was mentioned, over 40 years. I've been using virtual reality with my clients since 2010 because it is an extraordinarily valuable and flexible tool. Now, in terms of disclosures, I do want to say that I have been an early adopter and advisor to Amelia. I have software from Virtually Better Incorporated. I'm on the scientific advisory board of SciTech VR. And of course, I get book royalties. So as I speak, as I present, I would like you to keep these questions in mind, all right? First of all, I want you to think about, you know, what types of clients you treat. What do your clients fear? What are they afraid of? What triggers their fears? What situations or activities, all right? Secondly, I want you to think about the therapeutic approaches that you use. What skills do you teach? What skills do you want your clients, your patients to have? And then within that context, think about how virtual reality might contribute to the effectiveness of your treatment, how you might use it. So we're going to start out with what is virtual reality and how is it created, and what kind of equipment do you need? Now, as you can see, right, this is an example of a virtual reality headset that is self-contained. And when you put this on, obviously you cannot see what is around you. You see only what is projected onto the screen. Now, it tracks your head movements, and some also track your body movements, so that wherever you look, you are within the virtual world created by VR. What you see and what you hear, the ambient sounds, are all part of this other world. And because you don't see the outside world and you're completely surrounded by the virtual world, you are what is called immersed. It covers you completely. And because it is so vivid, everything you see and hear is part of this world, you feel very present. Even though you know when you put on the headset, that you're putting on a headset, the impact of being within a world where everything you see and everything you hear is part of that world makes you feel present. Okay? So let's talk about, what is seen. If you could look inside the VR headset, there is a split screen. Each one of these is lined up with your two eyes so that it creates a three-dimensional experience. Please be sure that everyone mutes themselves. Okay. And so this creates a 3D experience. And this can be created either, what you see can either be created through computer-generated imagery, or it can be an actual photograph or a video of a real situation, a VR video. So I'm going to show you some examples of both types, right? This is a computer-generated fear of driving virtual environment, right? Now, you can see this is a generic bridge. It's not an actual bridge, as opposed to this, which is an actual VR video of a specific bridge. This is, in fact, the Golden Gate Bridge in San Francisco. And there is a video of this actual car driving over the bridge. So I'm going to talk about the pros and cons of the two ways of creating VR. Again, this is a fear of public speaking scenario with what are called avatars, computer-generated people, not real people. This, on the other hand, is an actual video with real people in a real specific room. So what are the advantages and disadvantages? Well, if it is created by computer coding, if it's a computer-generated imagery, CGI, there are a number of very strong positives. First of all, because it's created by computer, it can add in variables. So it maximizes your chance as a therapist to vary, control, individualize the client's exposure. I'm going to use client and patient interchangeably. I don't know which is more comfortable for you and more familiar. I used patient when I was working with Kaiser, which was a medical center. I use client in my private practice. We're going to accept them as synonyms, if you would be so kind.
Yes, and here in Lebanon, we use also beneficiaries.
Ah, I love that. The beneficiaries. What a marvelous term. Yes, yes, and hopefully they will all benefit. Isn't that the point? Yes, I will love that. All right, I will throw that in as well. Thank you. So now one of the beautiful things is if it's all computer generated, then ideally every aspect of it could be changed. Now, that takes a lot of engineering. It's more expensive to and more time consuming to create, but it gives you alternatives like changing the skin color of your beneficiaries, of your clients' self-avatar. So if I'm being treated for fear of, say, driving, if I see my hands on the steering wheel, but if I'm dark-skinned and the hands are light-skinned, it interferes with my sense of being present, of feeling like this is real. So if it's computer generated, Some of them offer you the option to really adjust and match your client's skin tone in their self-avatar. Does everyone know what a self-avatar, what I mean by that? Okay.
No, I don't think so. Just if you can explain it a bit.
Excellent. So an avatar, if we go back here for a second, these are real people. These are actual people. These are computer generated images of imaginary people, and they are called avatars. Okay. Now, when you yourself, when your client, right, the beneficiary is seen, is at least partly seen, like here you see hands on the steering wheel. If you want your client to believe that they are the ones driving the car, you would like the skin tone of their hands and arms to match their own skin tones. This would be their self avatar. And that may become clearer as we
Yes, thank you.
continue to do this. All right. Also, if it's computer generated, then you may change the signage. In other words, the words on the sign. Let's say if you're going to an airport with someone with fear of flying, you would want the signs on the airplane and the signs in the airport, ideally, to be in your beneficiary's language that they speak. And if it's just a video, it's whatever you've taken a video of. You can't change it. But if it's computer generated, then some products offer you the option to change the language in the signs. And if there are recorded conversations or comments as part of the virtual environment, as part of the experience, some products allow you to change them from English to Spanish to French. And that may be very relevant depending on, who you're working with. Now, what are the disadvantages of computer generated? Well, the other people, the avatars, right, can look a bit cartoon-like because they're not real. They're just, they're created by computer coding. The virtual environments, the objects in the virtual world in the VR are generic. In other words, they are not specific actual places and bridges. They're sort of general, generic bridges, highways, elevators, school situations. And those may or may not be similar to what your clients, your beneficiaries, school or elevators or highways or bridges look like, right? I'm not aware of any products in Arabic. And as I was just saying, the virtual worlds, the virtual environments may or may not match, may not be similar enough to your Lebanese real environments to be evocative. In other words, to feel real. At the same time, I have to emphasize, when you put on that headset, you are taken into another world, and it is surprising how people respond to it, even if it's generic, even if it's not exactly like their own world. Now, there are also, however, advantages to using 3D, in other words, three-dimensional, so it's completely surrounding, virtual reality photos or videos. So these are taken with a special camera, so that if you're in a VR video, say of driving over the Golden Gate Bridge, a specific bridge, you can turn your head and you see the cars, you see what's around you. Again, it is completely, you are inside another world. However, if the video moves you, you don't control it, your client doesn't control it, and you don't control it. And movement without control can trigger some nausea, right? If it's recorded, you have almost, you may not be able to change anything in it. It's recorded. Some video recordings do have a few variables. For example, if you're driving, you may be able to make it look dark, or you may be able to add the sound and a little bit of the look of rain. But basically, if you took a video of a car driving over a specific bridge, that's all you can put your client into. That's what it shows. It's a video. You can't change it. And there are, not to my knowledge, and this may be changing as VR gets more accepted and there are more VR options, there are no VR videos filmed specifically in Lebanon. So what equipment do you need? Okay. Well, as the therapist, obviously you need some kind of computer, a desktop computer, a laptop, a tablet. You need something so that you are able to, through the internet, connect with your patient's VR headset, right? And you have to have a headset that displays the VR therapy product that you're using. Some VR psychotherapy products work on some headsets, some don't, some work on different ones. So that's, you have to make sure that the headset matches the product that you have, okay? Now, I don't know about you, but, particularly after the COVID pandemic, uh, nearly all of us moved to offering at least some in-person, but some remote teletherapy. So the client is not with you, the beneficiary is not with you in your office, they are someplace else. So what do you need? You can actually use virtual reality in remote teletherapy. But what do you need? Well, you need your computer, right? You need an internet connection between you and your client wherever they are. And you need a virtual reality psychotherapy product that allows you to remotely control what is displayed in the client's headset. Now, it's really the same as what you do if they're sitting next to you in the office. It's just you have to have a product that works over the internet and connects with their headset. And I'll show you some examples of different headsets. Here's the one that you saw before. This one is a heavier wired headset. You can see it is attached by a cord, but there are headsets that can hold your client's phone or that you can use in the office to hold your phone that are inexpensive. And you basically put the phone in there, you download an app, a VR app. The app displays, again, here's the split screen, and the headset simply holds the app, the phone, and that's much less expensive. Now, and I see that there is a chat, there we go. It is displaying wonderful, great. It's just a hello message. So, if you don't want to buy a $500 headset, depending on the product you use, if the product can display on a phone through an app, it allows you to buy an inexpensive headset that it matches the phone, that is compatible with the phone. It allows any beneficiary that you want to work with anywhere in Lebanon, if they have an internet connection, if they have a mobile cell phone, if they download the app and they purchase, it could be even a $12 cardboard headset, although I don't recommend it. If they can at all afford it, getting a headset that's maybe between $35 to $50 that is compatible with their phone, you can work with that client anywhere. Now, there are some extra equipment that some people use. There are controllers. I'm going to show you what that means. Whoops, sorry. These are controllers. When you have a VR product that allows the person to move themselves, allows your client to move themselves through the virtual environment, they would need controllers where you hold them and you push buttons to move yourself backward or forward or around. Some therapists use a biofeedback device to maybe track speed and depth of breathing, or to track galvanic skin response as a measure of anxiety. There are even some products that have a vibrating platform or have smells that are associated with the virtual world. And if you are working with beneficiaries. If you're working with people who have been in a war and have war-related trauma and PTSD, there's a very complicated but very effective virtual environments that can have the smell of bombs going off, or it can have a handheld fake gun that can vibrate and have the sound, and you can see this soldier is wearing a VR headset. Okay. And I'm just looking, look, what about sounds? There are no headsets. Ah, excellent. All right, very, very good questions. So if we go back to the question of, well, if the client is far away from you or even with you, and they're just using their phone to display the virtual environment, how do they get the sound? It comes through the speaker on the phone, just like you would hear someone who calls you. And that seems to be absolutely sufficient. Starting with the pandemic, I have treated my clients, all of my clients, through remote teletherapy, and I've had excellent success. I will talk about some specific apps and specific products, but I want to try to avoid being seen as promoting any particular product. So I'll talk more about how you can choose the VR psychotherapy products that are best for you. If you are going to treat war-related PTSD, I would please recommend take a look at the research literature that is specific to this. So these would be the research writings by Albert Rizzo, R-I-Z-Z-O, Albert Skip Rizzo, R-I-Z-Z-O, Dr. Deborah Beidel, B-E-I, D-E-L, Dr. Barbara Rothbaum, R-O-T-H-B-A-U-M. Please mute yourself. Someone's unmuted. And Dr. Joanne DeFede, D-I-F-E-D-E. I'm going to focus more on the other anxiety disorders, phobias, panic disorder, and why is the chat not showing up? You know, there are always tech glitches, aren't there? I think that's something the pandemic taught us, is there's always tech glitches. All right, my apologies. I'm not able at this moment to look at the chat. Please feel free to, yeah?
Yes, they're asking if it's just, I just need to know if it is available somewhere.
Yes, yes.
Which,
Everything I am showing is available. I'm sorry.
no,
And
no,
was that
that's it.
the,
I'm just reading what.
excellent. Thank you. All right, so let's talk a little bit about what are the virtual environments that are available, right? And what does the research show? I mean, is it effective and why would you use it? And then we're going to cover any risks and common concerns that therapists have about using VR. So there are more than 50 virtual environments designed for psychotherapy. It ranges from virtual environments about fear of insects like spiders or cockroaches to virtual environments where you're in a bedroom and perhaps someone had been molested, or maybe they're afraid of the dark. Claustrophobia environments like elevators and a room that you can even move the walls in. Fear of the dark, fear of dentists, driving, needles, elevators, fear of vomiting. I mean, right? More than 50 virtual environments. And VR is being created to treat more than just anxiety. It's also being created and researched in treating body image disorders and eating disorders. It's used for it can give you the stimulus for something called eye movement desensitization and reprocessing. Shopping environments for what's called interoceptive exposure. This is very important for panic disorder, where you're afraid of sensations inside the body. Intero is inside and septive is feelings. So it can offer changes in heart rate, the sound of over-breathing, hyperventilating. There are many, many relaxing environments. It can be used to train skills like diaphragmatic breathing, breathing deep in the belly rather than high in the chest, training focused attention, progressive muscle relaxation, relaxing all the muscles, mindfulness. So, substance use, so many things are available. And I want you to know, there is research now, 3 decades, over more than 3 decades of research on this, study after study after study, showing that it's effective. It's in adults. It can be used with people, with elders. It can be used with children with on the autism spectrum disorder. It's being used for social anxiety with children and teenagers. It's been researched and used and found to be effective worldwide. It's been used in medical inpatient settings. It's been used for physical rehabilitation. It's even been used with people with mild cognitive impairment. So, it's just been studied on, just there's so much research. This is absolutely an evidence-based intervention. I am going to here in these slides just give you a few key research studies, right? And then there are many, many more in the list of references. But, what are the key questions? Is it going to really evoke a physical response, an emotional response? And if you look at the literature review that was done now a decade ago, even then there was enough research that showed clearly people responded physically. If you, for example, if you were trying to help people stop smoking, if you put them in a virtual environment with cues for smoking, they had the urge to smoke, right? People with height fear got anxious. Musicians who had performance anxiety, if they were put in virtual reality, had the response. Flight phobics responded. So you respond emotionally and physiologically. It is as effective. Exposure in virtual reality is as effective as exposure in vivo exposure in real life. In other words, the gold standard, the proven effective. And that's what really convinced me to start using VR. I mean, not only does it evoke a response, but it's as effective as the best treatment we know. And even more, the changes that happen when they have the headset on in the virtual world transfer and generalize and show up in the real world. And VR is accepted. It's not just, only good for teenagers. I have treated people in their 70s and 80s. Frankly, at this point, my caseload is probably 75% from beneficiaries who sought me out specifically because they're looking for virtual reality exposure therapy, because they have heard how effective it is. So a meta-analysis of randomized controlled trials, 30 studies with over 1,000 patients and multiple anxiety disorders showed that virtual reality exposure therapy was effective, right? And I love this reference because here they actually compared it to, does it work in real life? In other words, they used a behavioral approach tests. So in other words, if you're afraid of spiders and you're willing to touch a spider in virtual reality, they then would bring out a real spider and see, are you able to get close to the spider? And are you really able to get a lot closer than you did before treatment? They really tested, does this change your behavior in real life? And the answer is yes, it does. All right. Now, I'm going to talk a little bit about the best way to do virtual reality exposure. Let's start first by just what does the research tell us? when we think about what have we learned, that we put people in a headset and they know they're putting a headset on, but it is so surrounding, it is so immersive, it feels so present that people respond in their body and with their emotions. Your beneficiaries accept it. It's effective with a wide range of clients. It is as effective as the most effective treatment we know. And the results and the changes move into real life, show up in real life. So why would any therapist not be using it? I mean, this is like, I read the research on this and I'm like, I have got to have this. I have to have this for the people I work with. So here are the concerns the therapists often voice if they've never used virtual reality. First of all, they worry, well, if my beneficiary has a headset on, they can't see me. Is that going to hurt our alliance, our relationship? And no, there have been 3 studies that specifically looked at this, and it did not hurt the relationship. I want to tell you, in my experience, it actually strengthens the relationship because I am offering them the most effective treatment. And I am also talking to them the whole time they are in VR. So I am with them kind of as a voice in their head while they are there, which is good because it doesn't make me a safety signal. If I were there physically with them, I could be a safety signal, which interferes with treatment, right? When someone faces something that they fear, you want them to feel that they have changed how they respond, that they are able to cope with it, that what they think and say to themselves has changed. And so having your voice in their head and you talking to them in VR helps them change what they're thinking without making your physical presence a safety signal, right? They still feel that they have made the change. So the second concern is that therapists think, well, it's going to be too hard to learn or use. I'm not tech savvy. Well, I want you to know I've got to be probably one of the least tech savvy people. No, I think I was the last person to get a microwave. I was probably the last person to get a VHR. I still use DVDs. I mean, I'm not a tech person. Um, VR really is fairly intuitive. It's fairly straightforward to understand and use. It takes a little bit of time to to become familiar, but it doesn't take that much time. And but I'm going to ask you to just read the chat questions if there's anything that should be addressed now.
Yes, we have 2 questions, Doctor. The first one from Siham, she asked, how much time can a person put the headset on his eyes?
Excellent question. There were warnings at the beginning, but I have found that unless the person gets queasy, has nausea, I can spend most of a 60-minute session with them in VR.
Okay, and you have the second question also from Sumaya. During the session, can the therapist see what the client sees? I think this
Excellent. Yes,
is
yes,
depend on the
indeed.
application.
Exactly. Yes, you actually see what they're seeing, and I will show you examples of therapist control screens so you have a better sense. But you will be able to see your controls so that you can choose your beneficiary's experience so that you can offer them what's called graduated exposure so they don't get overwhelmed, right? And so you give them the experience that will be most helpful to them, and you see what they're seeing and where they're looking. Okay. Does it require expensive equipment? It depends on the product. It's becoming less and less expensive over time. When I started in 2010, into 2010, so 14 years ago, it was $22,000 for a virtual reality setup that only treated 3 fears. Now it's a tenth of that. And I believe that with time and with competition, the cost will decrease. So what are the actual risks of virtual reality? And again, please interrupt me. I see there's some more questions, I believe.
We have some comments also. Siham said that because she put the headset for 5 minutes, she felt the headache. And
Oh,
Sumaya is commenting, and this is important for the therapist to know the client's experience, to ask for any headaches, nausea, dizziness, and if they have any previous illnesses or something like that before you start this kind of therapy.
the only previous illness that you might want to ask about is whether they have seizures and whether the seizures are controlled. Sometimes they're called, and check with their doctor, but that is the only illness that you really need to know about. Now, there are some real risks. Yes, they can get queasy or nausea. It is possible to get a headache. You might want to pay attention to, did you have the headset on? Was it a heavy headset? I've not had headaches been a problem for any of my beneficiaries over the years. I have occasionally had a client who couldn't use it for very long because of nausea or queasiness. But again, that's been very few. Now, you're more likely to have your beneficiary get nausea if they feel like they're being moved, like if in the virtual environment they're being moved, but they're physically sitting still, because then there is a disconnect between their body, which says, I'm not moving, but their eyes, which say, but you are moving. And that disconnect between the eyes and the body can cause nausea. So if that happens for someone, I have them close their eyes while the body is being moved and then open their eyes when they're in the new environment. The problem with falls are, remember, your client cannot see what's around them. So particularly if they are standing up, make sure that they don't start to move and trip over anything, but you can see them. You can see them and you can see what they're seeing. And most of the time you can do therapy with them seated so they will not fall. The final real risk is what's called sensitization, increasing fear. And this occurs if you do not prepare them for whatever they're going to experience. And if you don't explain to them and describe to them in detail beforehand what they're going to experience and get their permission, right? You would not have somebody do something that scares them without giving them ways to tolerate their anxiety, giving them, some tools to deal with their fear. All right, there's another comment or question.
No, nothing. Just Siham, she said that maybe because it was the first time she used, or is the first experience with VR an important experience, different from the second.
I have had, I know at least one woman who became very queasy the first time and just started practicing with smaller and with small times in VR and gradually was able to be comfortable. That may be the same thing with headaches, or this may not be something that you can personally use, but that your clients, your beneficiaries may be able to use. One other comment or question?
Does any panic attack or any seizure, epilepsy seizure affect this type of therapy? Sumaya is asking that.
All right. If your client has seizures, check with their doctor to make sure that it would be safe for them to put on the headset, right? But if they have panic attacks, oh, this is one of the best treatments you can do, right? So, do your usual treatment for getting over fear of panic attacks, and that is covered in my book, Overcoming Anxiety and Panic, interactive guide. That will step you through everything you should do with a client, with a beneficiary, to help them get over the fear of panic. And then the virtual reality helped you put them in the situations that would have caused them to panic, so that they learn not to panic, that it's not dangerous. So that's actually moving very nicely into when and how do we use virtual reality in therapy. So there are many applications of virtual reality. It's used to treat anxiety, but also to treat depression. It's a way to learn and practice skills like I talked about: relaxation, calm, mindfulness, breathing. It's being used to treat addictions and substance use. It's even being used for people who have auditory hallucinations or have eating disorders. It's for pain relief. So we're going to focus, however, on its uses with anxiety. And there are 8 clinical uses in anxiety, right? The first is it helps someone relax more deeply, more quickly, more effectively if they are in an environment that feels relaxing to them. It also helps them develop what's called self-soothing or grounding skills. It increases emotional engagement because it feels so real, and it gives them hope because they know that you are offering them the best treatment. You can give them experiences that are positive and bring on positive emotions, and use those experiences to reward them for working in therapy, or to end a session on a positive note of relaxation or pleasure or awe or wonder. As I mentioned earlier, it can help them learn and practice skills. When you put them in virtual environments, you and they may discover that they were afraid of certain aspects of the environment that they had not realized. So now you can address those. It also helps sort of confirm the diagnosis. Oh, if you put them on the plane, are they afraid of the plane and they have flight phobia? Or are they afraid of their panic, in which case they have panic disorder? Or are they afraid of the germs from other people, in which case maybe they have the obsessive compulsive disorder or health anxiety? So it can help confirm the diagnosis. It's a wonderful tool for exposure and desensitization. And I use it to test that the skills that I believe my beneficiary has to tolerate and use their anxiety actually work. Because I put them in a situation that triggers some of their anxiety. Well, can they use the physical skills to calm themselves? Can they use the cognitive skills that we've been working on to change their beliefs, to change what they tell themselves? Or are they not able to do that? Are there fears we haven't addressed? So I can see that what we're doing actually works. And then I can push them to try and become afraid, and see that even when they're trying to be afraid at the end of treatment, they're just not that scared anymore. Some of the virtual products also allow you to add in some interoceptive variables, like the sound of overbreathing or the sound of a rapid heartbeat. And because you could put them in some different environments, we know that the more new skills are practiced in different environments, the more generalization there is in real life, and the more relapse prevention there is. And that is all shown from research. So let's just cover any questions or comments so far that have come up recently.
I believe we answered all the questions in the comment. If anyone want to add any questions or
Excellent.
something.
All right. So let's really focus on how do we use VR for exposure therapy. All right. Now, we already do, I hope you already do exposure, some form of exposure in treating anxiety, because if we fear something and we avoid it, we will remain afraid of it. If we fear something, but we never face it, how can we learn that we can face it? So what are the alternatives that we have now without virtual environment? Well, we can have someone imagine facing their fears. And it has advantages, obviously. They can always imagine, right? And what they imagine is personal to them, but it has significant disadvantages. You really do not know. You can't see what they're imagining. You don't control what they're imagining. And what they imagine may either be too scary, too vivid, or it may not be vivid enough. In fact, research shows that the capacity to create vivid images declines with age, right? And some people, frankly, have never been very good at creating vivid images. So we've got imaginal exposure. We have what's called in vivo exposure, real life exposure. Major advantages. It is shown to be effective. It's the standard against which other treatments are measured, right? But it also has disadvantages. When you ask your beneficiary to go out and face something that scares them, how many times do they not do it? They come back and they say, well, I was too busy, or right? So if you have to have them do it alone, they're alone, they don't have you guiding them. You don't have them, you're not there supporting them. They may not do it. They may get too scared and then become more scared and sensitized, or they may use safety actions which take away from the benefit of the exposure. If you go with them, then you're doing their therapy in public, and that raises issues of confidentiality and privacy. And frankly, there are some things that are difficult, expensive, or even impossible to do. Unless you really have an extremely wealthy client who is, say, afraid of flying, you can't have someone go on a plane and take off and then take off again and then take off again and then take off again until they're not afraid of takeoffs anymore. But in virtual reality, you can. In virtual reality, you can control the weather. Let's say someone is afraid of public speaking, you can control how the audience responds to them. You can control the amount of turbulence on the plane. You can take off as oftentimes as you want. You can control the speed of the car if they're afraid of flying, and the type of highway that they're on. The intensity and the pace is controlled to optimize your beneficiary's success, so that you can slow down the exposure or speed up. You can pause and repeat as often as necessary. It just bridges that gap between talking about doing something and actually doing it. So they do it in VR in the session with you. Now, are there disadvantages? Of course, not everyone responds. Although there are all those virtual environments that I talked about, over 50, there's not everything. Like there's no virtual environment for ski slopes, for example. When it's computer generated, which those other people, the avatars, can look a little like cartoons. They tend to be Caucasian, white-skinned. We don't have any disability other avatars, and they tend to be cisgendered, which may or may not be a problem in Lebanon, may not be an issue in Lebanon. And the thing to remember, please, exposure alone is not treatment. Just putting them in the VR. The VR is a tool, not a therapy. So how can we use VR as an effective tool in therapy? And I believe there's one more comment. Comment or question?
No, there's no, it's a comment.
Ah, okay. So, what are the 7 secrets to effective virtual reality exposure therapy? Well, 7 secrets, 7 steps. One is create a shared understanding of why you're going to do exposure therapy by mapping out the client's cycle of anxiety. And let me show you what I mean by an anxiety cycle. I sit down and I talk with the client and I see, does it run in families? Is there a genetic vulnerability that explains, oh, it's not me, I'm not weak, it runs in the family, right? Look for any chemical triggers, either like medical illnesses, like hyperthyroidism that's causing heartbeat and nervousness, or mitral valve prolapse, that causes the heart to skip a beat, or chemical triggers like, do they have their panic attacks after they've been drinking, or after they smoke marijuana? But the 3 big triggers are these. What stresses do they have in their life? The more stressed they are, the more they're going to feel like they're under threat, the more they're going to react by having panic and anxiety responses, right? How do they talk to themselves? Are they critical? Are they negative? Do they make unrealistic demands of themselves that they should never upset anyone, they should never say no, that they have to be perfect, that they should never make a mistake, that they should never be anxious, right? Any of those, if we're demanding things that are impossible, because that's an impossible goal, we're going to fail, we'll worry that we're going to fail, and that becomes a threat, which again triggers anxiety. And then what has happened in their past that leads them to be anxious? Have they learned what I call unhelpful lessons from past events? And this could either be, I almost had an accident in the car and now I'm afraid of driving anytime. That's not helpful. I was on a flight with a lot of turbulence and now I'm afraid to fly anytime, any flight. That's not helpful. Or it could be very broad lessons like, I was abused, molested, beaten when I was a child, and now I trust no one. Or I only get involved with people who abuse me. Or I was sick as a child, or my family was sick, and now I worry all the time that I'm vulnerable. You look for beliefs that they have learned about themselves, about other people, and about the world, right? So that it makes sense. Why is a message of threat getting triggered, right? And then you explain that when the brain gets a message of threat, it goes to a primitive part of the brain that simply reacts. If that's the amygdala and a little bit the hippocampus, I simply describe it as I beg your pardon, this keeps the reacting brain that reacts automatically. Oh, there's threat. And it triggers sympathetic nervous system arousal, triggers the panic or anxiety response, and floods the mind with thoughts of danger. And if we don't understand that this is a misfiring, then we act as if we're in danger. And we leave, we avoid, we start being on the alert for danger, being hyper vigilant. We start to do safety actions like, I felt like I couldn't breathe, so I have to keep the windows open in the car all the time. I have to be by the door to leave the room. Things that make us feel like when nothing bad happens, it's not because there was no danger, it's because we did these things, or become frightened of our anxiety response, and we try to fight it and stop it out of fear. So we map that out so you understand what they're doing, right? And then you teach them some skill to tolerate anxiety, breathing, relaxation, mindfulness, could be any of that. But it's not to stop anxiety, right? Because that's fighting it because you're scared. It's more to just tolerate that there's this misfiring. And you explore, what fears do they have? And you help them together look at those fears and see, do the facts support those fears or not? Because if you're panicking because you're really in danger, then yes, leave and don't go back. and do things to keep yourself safe and fight if you have to, right? These are all actions that are life-saving when this is a true alert that we're in danger. The trouble is with anxiety disorders and panic disorder, it misfires and goes off when we're not in danger. So now you've understood what triggers their fears and where it came from. You have given them tools to tolerate the anxiety. You have identified and explored their fears and decided that they are either realistic or not realistic. And now you have a hierarchy. In other words, you have a sense of what makes them the most scared, what makes them the least scared, so that you can gradually start lower and work higher. And in virtual reality, you work as a team. You are collaborative. You start with a virtual situation that would be less scary for them. You describe it to them, and you get their permission to face that virtual environment. Tell them that they can expect anxiety. You should expect that they're having anxiety. If they're not having any anxiety, they don't have the chance to learn anything, right? And while they are in that environment, don't just leave them alone. Talk to them. Ask them, what's your anxiety level? 0 to 10, where 0 is not at all and 10 is extreme. Now, what's your fear saying? What are the facts? What are you going to say back? How are you? What's happening in your body? Okay, let's do your breathing. Great. What's your anxiety level now? Oh, it's gone down. That's wonderful. Think about what you're doing that's making that possible, right? And then as they get better, test that they can actually use those skills. So this is a diagram of what treatment actually looks like, right? You try to get them to stop any chemical triggers. You try to help them deal with stress better and change what they can and leave a stressful situation if possible. But if not, you help them accept that there are some things they can't change or leave. You help them change the way they talk to themselves so it's supportive and realistic. You really have them ask, is what I'm telling myself true? And is it helpful to talk to myself this way? How can I talk to myself in a way that's more helpful? And you help them rethink and get over lessons from past events. And as they go into the virtual environment and they have an anxiety response, you help them accept the anxiety and do diaphragmatic breathing with the belly, with the stomach, low down. I use this tool all the time. I have them with them. I have a 2-column dialogue table where they write the fears on one side, and then we write all the facts and the logic. And then we decide, do the facts support it? Are they really in danger? Or is it a false alarm? And if it's a false alarm, then we know that they have to face what scares them. They have to act on the facts, not the fear, and face their fears long enough, accepting anxiety, to make it another fabulous opportunity for growth. And that's the only way that this brain, which learns from experience, not words, learns that they can face what they fear and be all right and be safe and cope. All right. I believe there is an additional comment or question.
Yes, we have a question from Rita. She's asking how it could be used in depression, please.
So the way it's being
virtually.
Right, the way it's being used in depression is to put them in virtual environments that lift their mood and give them positive emotions. It's also being used to help them change what they tell themselves in situations that would make them depressed. Let's say they are at home and they think, oh, why should I go out? It's probably going to be miserable anyway. I'm not going to enjoy myself. And then they would practice talking back to that negative self-talk and saying, no, when you go, you usually have a good time. Let's just go and see. You can always go for a little bit. And how about if you get out and exercise, because exercise is going to make you better. So it helps them practice the cognitive changing in self-talk in different environments. And it helps put them in environments that change their mood and their emotion.
behavioral experiments we can do in the clinic. This is what you mean, right?
Yes, exactly. Thank you. So I talk about monitoring your client's response, your beneficiary's response. What do I mean by that? Well, you will be able to see them as well as seeing what they are viewing, right? So you watch. Are they tense? Are they sweating? Are they flushing? But this is what I find most useful. I simply ask them, right? Because we're all going to be anxious at times. But if we feel that we can tolerate the anxiety, that we can cope with the anxiety, then anxiety is not a problem, right? But I do want to see that their level of anxiety goes down. So I ask them frequently, what is your level of anxiety from 0 to 10? Where 0 is not at all and 10 is extremely anxious. And ideally, I want them to have it somewhere in the middle, the high middle, and go down to the low. I want to see if I say to them, what's happening in your body? And they feel like, I can't breathe. You say, okay, relax the muscles like we talked about. I want you to notice if you're breathing tight with your chest. I want you now put a hand on your stomach. Breathe with your stomach. Slow breath in, slow breath out. Can they do that? If I say to them, oh, what is your fear telling you? Now, what are you going to say back? I want you to know that I want to see that they're able to change what they tell themselves to talk back. There are also, if you use biofeedback, you can use biofeedback as a way to monitor the response. The other way, there are 4 other ways. Are they progressing through the hierarchy? In other words, if they were afraid of driving, and so first you had them drive in a virtual city at a slow speed, and then when they got more comfortable with that, you had them drive in the city, but now they heard the sound of an ambulance, and they were still okay. And then you had them start to drive on a highway, but in the slowest lane until they got comfortable with that. And then you eventually have them drive in the fastest lane at the fastest speed and going over bridges and going through tunnels, and they're okay with all of that. In other words, they progress through the hierarchy of fears. I also, just like I asked, what's your anxiety level from 0 to 10? And I want that to go down because 10 is high fear. I will ask them, how much do you believe this fear? Your fear tells you you're going to crash. The fear tells you the plane is dangerous. The fear tells you that you have to be perfect in public speaking, and if you stammer or if you miss a word, that everyone will think that you're stupid. How much do you believe that from some 10? Absolutely, I believe it. To 0, not at all. And I want that level of belief in the fear to go down. And then on the same 0 to 10 scale, I want their belief in the facts and in their new self-talk to go up. So the belief that I can talk and I don't have to be perfect and it's still okay. How much did you believe that as we started therapy? 0. I didn't believe that at all. And how much do you believe that now? It's like an 8. That's what I'm looking for, right? Decrease in anxiety, decrease in belief in fears, increase in belief in facts and in the new cognitive self-talk, the new changes. And then here's the relapse prevention to really test, has the treatment worked? Is after they are no longer scared, I put them in the scariest virtual environment, and I say to them, I want you to make yourself as scared as possible. Tell yourself all the things that fear will tell you. And what they find is that even when they're trying, their anxiety doesn't go up nearly as much as it used to. And then I will say, oh, look, it's only a 4 and it used to be an 8. Now, use your skills and bring it down. And usually they bring it down very quickly. And this really shows you and them that when they get anxious in a real life situation, they will be able to use their skills. So I've talked about theory, I've talked about research. Let me talk about actual patients, all right? Actual people that I have worked with. Now, I am changing some of the details so that no one could identify the specific beneficiary, but these are real cases. So this was someone who had a fear of driving, particularly over bridges and heights, and they had panic disorder. So we did the treatment for panic. They had a genetic tendency. They had an uncle who had a driving phobia. They had a history, a generational history of trauma. Grandparents on both sides of their family had been in refugee camps during World War II, and many family members had died. There were chemical triggers. This was a female, and she was postpartum, so she had the hormonal changes, which can make anxiety more likely. And she had a great deal of external stress because she had both a high-powered, demanding job and a new baby. And she had very high self-demands. She wanted to be perfect in everything she did. And she had had unhelpful past experiences. First of all, she had seen her uncle avoid highways, but she had also had 3 car accidents. She had been rear-ended on the highway. She'd had an accident on a bridge, and she'd had an accident on a hill. So here was her diagnosis. Here were all the symptoms she got. She had the heart palpitations. She got sweaty. Her hands and her head would shake. She was tense. She had shortness of breath, feeling like she couldn't breathe. She felt like her vision was getting dark, right, because of some of the tunnel vision and the spots that occur with panic attacks. She afraid that she would have an automobile accident, a car accident, because she was out of control, that she would go out of control, that she would veer out of the lane, or that her hands and arms would be locked and she would not be able to move, and therefore she would cause an accident. And so as a result, she avoided hills and tended to not drive. She was hyper vigilant, always looking, this car's too fast, that car's too fast. You know, she had a lot of safety actions, stayed in the farthest lane so she could pull over and get off if she needed to. She drove too slow, and she tensed to try and stop shaking. Now, here is her, this is, for those of you who are not familiar, this is the SUDS, Subjective Units of Distress Scale. This is the 0 to 10, how anxious are you, right? So this is what she tells me. I put her on the bridge, and she immediately pops up to a 5 on a 0 to 10 scale. And she's saying, I'm on a bridge. I couldn't get off if I had to get off. She thinks she might have to get off. We do the breathing. We talk about why would she have to get off? She wouldn't have to get off. This is just driving. We put her on the bridge again, and it goes up, but it only goes up to a 3. And we stay on the bridge. I ask her to do the breathing. We go over the facts, and it drops down almost to a 1. And she starts to now see some facts that she hadn't even been aware of, like the speed limit isn't as fast as she thought it was. We put her on the bridge again. I tell her to make herself as scared as she possibly can. It only goes up to a 4 and quickly drops to a 1. She looks around and she says to me, it's beautiful. In one session. We've spent 4 sessions preparing and treating everything else. This is session 5. And now we wanted to deal with her fear of heights. And here were her symptoms: dizziness, shakiness, sweatiness, palpitations, heartbeat. She was afraid that she would get dizzy and collapse and fall and therefore die. And so she would leave places or avoid or grab on. So I put her in an outdoor elevator farthest from the edge, and she was at an 8. She was extremely anxious. We went over the facts about Just because she's standing and shaking, that doesn't mean that she falls. She's never fallen in a panic attack. She doesn't have any balance problems. It drops only a tiny, tiny, tiny bit. You know, I have her go forward a little. And then what I did, this was in person with her. I said, with your permission, I'm going to put my hands on your shoulders. I'm going to move you back and forth. And your fear says that you're going to fall. I want you to make yourself fall. And I had my hands on my shoulders in case she actually fell. She didn't fall. And at that point, because she had truly faced her fear, it dropped to a 2. What happened in real life with this client? She began driving the hills, the bridges, the highways, first with fear, first deliberately, and eventually she said, oh my gosh, I realized I was driving and I didn't even notice. And this is what she said. This is awesome. I never thought I could do this without medication. I've never had a breakthrough like this. Any comments before we go on to the next case?
Sumaya, I understood that the exposure is not continuous.
I'm not quite sure. I understood that exposure therapy is not continuous.
I mean, maybe she's asking if you, Sumaya, if you can open your mic and ask the question or write it again more clearly, please.
Maybe it's about that we did a lot of exposures in one session.
She means that you stopped. You stopped in the session. You stopped. It's not in like one long exposure session.
Yes. Oh, excellent. Yes. If they are doing well, they might stay in the VR, but I would change the environment. If they are not doing well, I would stop, maybe have them take off the headset, and then we would talk about what were they afraid of and go over what are the facts, talk about what scared them, and then go back and try again, or maybe even put them in a relaxing environment to help them calm down and be more prepared before they face, or talk about maybe what we tried to do was a little too big a step for them. So the exposure can be continuous or it can be interrupted, and it can be to the same environment until it drops down, or it can be to different parts of environment, or it can be different environments entirely, like with this case that we're coming up to. This was someone who had flying phobia, but also had an anxiety disorder, not otherwise specialized, a personal history of abuse, a lot of work stress. Her triggers were that she had, again, genetics. Her mother and her grandmother were anxious all the time, and she said they're afraid of everything. This is a woman who was an immigrant, so she had that stress. She was in an unhappy marriage and a stressful job. She demanded so much of herself. She said she felt like she had to help everyone. And again, to be perfect. She had been molested by strangers and molested by a family member. Her father was verbally abusive and she had been hit. And she had had some turbulent flights where the plane dropped and the lights went out and everything tilted. And she had also been on another plane that had been hit by lightning. So she was very afraid of flying and generally afraid of a lot of things. She had a lot of muscle tension when she got scared, shakiness, pressure on her chest, shortness of breath, the palpitations, the heart palpitations. She had nausea when she got scared, and gastrointestinal upset, like nausea, diarrhea, cramping. And her fear was that the plane was going to crash because of turbulence, or that it would run out of gas, or that it would get lost, or that there was a terrorist on the plane. And she had just general feelings of she didn't trust other people and hated feeling powerless. So she either avoided, she took Xanax. Now that's an anti-anxiety medication, which is a sedative. And if you take that, it may relieve your anxiety, but it may not. And what it does do is it will interfere with your learning that being on the plane is safe and that you can handle the anxiety without it. So anytime you do a safety action, it actually interferes in treatment, even though it makes the anxiety less at the moment, but it maintains the anxiety over time. She would try to distract herself and not be there physically. She would sit by the front to try and minimize turbulence. She would be hyper vigilant, and she was looking out the window to make sure that the plane wasn't falling. And when she wasn't looking out the window, she was looking around at other people. Are they afraid? Are they afraid? You know, and then she would look. Are there agents on the plane that would save us? You know, are there terrorists? Does anybody look like a terrorist? All of these things, of course, maintained her fear and kept her afraid. So she came in so tense, already at a 5 without us even doing anything, that I said to her, here are some environments that many people find relaxing. And she chose to be on a beach at sunrise in Costa Rica. And her anxiety came down to a 2, at which point I thought we could start to do some exposure. I put her in a car going to the airport. This is San Francisco airport, but SFO2 an airport, and it popped back up to a 5 again. But then we went over the facts. Planes are designed for turbulence. Pilots have thousands of hours. I beg your pardon. And it went down to a 3 and then a 2. I went to drop her off at the airport, went up to again, but only to a 4, not to a 5. And I prompted her to use the new ways that she was thinking about flying. Like, I'm looking forward to this trip. I'm choosing to fly. I'm using courage. People fly all the time. And she brought her anxiety down to a 2. It stayed at a 2 through check-in. But then I first put her on just on empty plane because she was so afraid of other people. It went back up to a 5. But we went over the facts. The flight crew does this for a living. Pilots do this for a living. They do this for 20 years until they can retire every day. Everything is designed for safety. We went over all the facts, dropped down to a 3, dropped down to a 2.5. I put her at the gate to get ready to go on a plane. It was only a 2. We boarded the plane, started, called for boarding. It only went up to a 3. And as she went on the jetway and boarded the plane, it went down to a 2. It stayed at a 2 when she was on the plane with other people. We went on the takeoff, it dropped to a 1. And by the time she was mid-flight flying, she said, I don't feel any fear. So what happened in real life? She said to me, for the first time, I watched a movie on a plane instead of looking out the window or checking everyone. She started out the night before. She was still kind of anxious, but she only took half the amount of medicine she usually took. And then she took no medicine for that flight or any other flights. Our treatment shifted to working on her work stress. And months later, she came back for one session about the flying anxiety because she had some flights scheduled. We put her waiting to get picked up. We dealt with her anxiety. It was a 4. She was able to change her anxiety and say, I'm going to enjoy this. This is my vacation. Her stomach was tense, so I had her do the breathing. It dropped down to a 1. The cab arrived. By that time, it was 0. She was in the cab going to the airport, no anxiety. She boarded the plane. She's on the plane, nothing. And she sent me a lovely email that she had a fabulous time. Questions or comments?
I don't have any questions in the comments here. I just want to raise up something. When we're doing virtual reality, sometimes beneficiaries have a different coping mechanism or coping skill, which is that they start to easing themselves more. It's not real. It's virtual reality. I'm not in this
Yes, right.
stressful situation.
Yes, and that's why you
And
want to
we
be
need,
talking. That's why you want to be talking to them and have them talking to you, because if I say, "Oh, how did you bring your anxiety down?" and they say, "Oh, I told myself it wasn't real," I'm like, "No, no, 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 no. Make it real."
yes, we need to figure that out during our sessions, not to be fooled by this coping mechanism that it's working.
Exactly. Exactly. Yes. No. We want them to be as real as possible. We want them to be present. So I'm going to go, and if I can, I am going to try to show you. Why is that not happening?
Can we help you with something?
Let's see. I'm going to try a new window. Ah, there we go. I will get this up. And I will just move this over here. And then I will do a share screen. And I'm going to show you a simulated session so that you will actually see what it looks like when you are doing virtual reality. So this is what I see. This is my therapist control screen where I can choose the virtual environment and the variables. Here is, I can see my client. I can see my beneficiary.
Maybe if you put it on full screen, it would be better for us.
I am trying to figure out how to do that. Some reason. All right. Move
Now
you
you're showing
over.
us the
Right.
Amelia, right?
Right. No. So, oh, crud. Pardon me. There, fear of driving. Pull that up, and I'm going to just move this over here. There we go. Thank you. All right. So we're going to start with her putting on the headset. So she's put on the headset.
We can't see it yet.
I can't see yet. Okay. Are you able to hear what I am saying, though?
Yes, we can see you.
Excellent. All right. So we're going to move to this. There. Are you seeing that now?
Yes, we can see it. I think
Excellent.
this is Amelia, right?
You should be seeing a therapist screen and a picture of a client with the beneficiary with the headset on. Are you hearing that? Are you seeing that?
Yes, we can
Excellent,
see.
excellent. Oh, wonderful. Okay. All right, so this lets me know I start the virtual environment. I've set the variables. I see what she's seeing, right? This is what she sees you.
Mm-hmm. This is a recorded session you took at your clinic, doctor, right?
Yes, this is a recorded session. Now, I hired an actress to play the client, so I am not breaching anyone's confidentiality and privacy, but this
Okay.
reflects exactly what I do. You can see here, I see what she's seeing, but I also see her to track her response. Here are some of the variables that I could set in advance. How many cars on the road? What kind of weather? What type of day? Is there a passenger in the car with her or not? Is she the driver or the passenger? And then here are variables that I can change during the environment, during her experience. She can make a left turn or a right turn. I can speed up and control the speed of the car. I can change the highway, right? It gives you this incredible ability to tailor it. And meanwhile, you can hear I am talking to her while she's there. What does the fear say? What can she tell herself? What's her anxiety level?
This is you are present there with her in the clinic, not remotely, right?
No, this is
Or
remote.
this is remotely.
This is remote. She is in
Okay.
she's in another state. She's halfway away in the country away from me.
Mm-hmm. Here I want to ask something. When you want to change any variables in the session, you will tell the beneficiary that now I will expose you to an increase in speed. I will expose you to more cars. You will
Exactly.
not do
I will not
anything
just
suddenly.
I will not do anything suddenly. I will not surprise her. The one very bad experience I had was where I did not describe a spider experience clearly enough. And the person became more scared, and that ended the therapy. We could not recover from that. So always I say, I get permission. Just like I explained, you're going to be on a kind of curvy road as you enter, right? Always let them
Mm-hmm.
know you're a partner with your beneficiary. And she turns her head, and I can see she's looking out the side window. So I'm getting permission before we move into the middle lane.
Mm-hmm. Now we can see. I think she's seeing like a video in 360 in VR, right? And you're controlling this video.
Exactly. So one of her fears was that if there was wind, it would blow the car off the highway. And so when
Okay.
we pass a big truck, and obviously there's going to be wind, I have her pay attention to, look, the car didn't move. And it doesn't matter that it's a virtual car in virtual reality. For her, that just happened.
Mm-hmm. Last
I
time
realize
when we spoke, you highlighted something that this environment, it doesn't necessary to be that real. even a
Yes,
cartoonish environment will trigger the same response as the exactly real environment. On the other
yes,
hand, you said it's better not to be that real because it's the bridge between the reality and this type of therapy.
that's right. If they could handle absolute reality, they wouldn't be in your office. They wouldn't be seeing you. So in virtual reality, sometimes less is more. You don't want the kind of virtual reality that gamers want, where they want extreme, vivid emotions. You want gentle enough that your beneficiary is willing to face what frightens them, what maybe terrifies them gradually.
We have a participant asking, I think you're gonna come through this in a minute, the applications or the softwares that they could use.
Yes,
Here, I believe
yes.
that there are some problems because most of the American websites or the Western websites are not available here to us in Lebanon.
Oh, oh dear. All right. All right. Well, then you,
That's with Amelia.
oh, with the exception of Amelia. Ah, okay.
Amelia, no, Amelia, it's not available.
Amelia's not available.
Let's start with it. Yes.
Okay. All right. Then it may be that, uh, well, there are a couple of possibilities. Do you, let me address this, and perhaps we could get back to this video if it would be helpful later. Would that, perhaps that makes the most sense. Why don't we address that
Bec
issue?
because we have lots of comments regarding this point.
Ah, okay. All right. So let's move to that. So how do you go about trying to choose a virtual reality product? Well, it has to be available. Now, there are several products in the United States that are available. One is Amelia, which has been purchased by XR Health and is now going to be called Mental Health by XR Health. There is Virtually Better Incorporated, Virtually Better Incorporated. There is a France-based VR company, and it is C, the letter C, two, the number two, right? And then the word care, CARE, and there is a dot, a period between two and care. So it's C, the number two, dot care, CARE. That's out of France. There is a company out of the United States called SciTech VR. That's PSYTECH VR. Sci as in psychology, SciTech VR. And there is company out of New Zealand that is focusing on self-help VR that is the letter O
OLV,
and capital VR.
it's not available here in Lebanon, this one also. It's an
How's that?
application via the mobile.
Okay, okay, that's too bad. All right, all right. Now I know that there are many more companies that are creating VR. Most of the VR software that's not being created specifically for therapy, right, specifically for exposure, is relaxation or mindfulness. You might take a look at some of the gaming VR. For example, now you'd have to be careful that it's not too intense, but Potentially some of the gaming VRs for driving might be used for driving phobia. You can also, do you get YouTube? Can you access
Yes.
YouTube VR
Yes.
videos?
Yes.
All right.
Yes.
All right. Look on YouTube for VR videos. Now, again, they're not created for therapy, so they don't give you control. They may be intense experiences, but you may be able to find something that clients may be able to use.
This is
Even
critical because
yes,
they are made the opposite way of therapy. They are made to trigger some fears and
exactly, exactly. Um, there are more apps, more VR apps being created. Um,
I
I don't know if there is if there are any VR companies in Lebanon that would be
I can
creating.
help I can help them with this maybe because I have done a little bit of research. If they want, they can contact me. I will help them with this idea.
Thank you. Wonderful. Marvelous. Marvelous. We had thought that maybe you could use a VR camera, but that seems to be more complicated to use than you would think. But if the VR cameras get easier to use, then you might be able to just make a video for any patient that's relevant to them. The other thing
I'm making
is,
a VR application for my thesis. I showed you last time videos from.
yes,
Uh,
exactly,
mhm.
exactly. And right now you can ask AI to create a 2D image of anything. I believe it's surely going to be coming that you might be able to ask AI to create a 3D image of anything that you describe. So that might also be an option. Okay. There's some technical, just practical issues. You know, if you're going to use VR, do you have a good internet? You know, if you're going to buy a product, how much does it cost and how much can you raise your rates or can you get more clients? Um, if you want more information, here's a free article. You can go onto ResearchGate and download the full article.
The
And I'm just
article
going to,
and the books you mentioned in the handout, right?
yes, yes, it will be on the handout of the slides. Exactly.
Yes, it's the end of the slides. Your two books and the article and the webinar also about needles. We
Yes,
will send them. We
excellent.
have the free article, virtual reality exposure therapy,
Mm-hmm,
bringing in vivo in office, and the
mm-hmm,
free with training webinar, treating needle phobia. Also, it's available on the slide.
mm-hmm.
And the two books, Virtual Reality Therapy for Anxiety, a guide for therapists, how it's available, the link, also the webinar,
And the client,
and
and
the
then
second book, Overcoming Anxiety and Panic Interactive Guide, also it's available in the handouts.
yes, this really steps through how either a client themselves or you can take them through overcoming fear of panic, fear of fear, right? And anyone who has a phobia is not only afraid of the situation, but they're nearly always afraid of their fear as well. So the skills here are almost universally helpful. If you wanted to see more about using VR for anxiety, the PESI.com has an online webinar. So I would like you to take a moment now and just write down what are your next 1, 2 steps that you're going to take. Maybe you're going to uh, look at the list of references and look at one of them, or maybe you're going to download that free article, or maybe you're going to look at the free webinar on treating needle phobia, or maybe you're going to reach out to Fuad and get information about VR options in Lebanon. We've sort of talked about the pros and cons of VR apps and YouTube, that they are cheaper and may be available, but they're not designed for psychotherapy and they may be too intense. So I want to thank you now at this point for your attention. I'm going to stop the share screen and let's see. And you can just either put questions in the chat or raise your hands. I'm going to just look at the chat here and see if there are any questions that I have not looked at. Is this real data? Let's see.
When you were showing us showing us the session,
Yes.
the remote session,
Yes.
they were asking if it were real data in the application.
This was we were really doing it. I was doing it with someone I had hired to play the role of a patient, of a beneficiary, and I explained very clearly, based on people I have treated, what the fears would be, so that it was a very realistic simulated session. Let's see, going through. From what age can we use VR? You know, it's been used with, I treat adults, but it has been used to treat children. You would probably start, my guess would you would go no younger than preteen. But I would look at the research on that if there is any and see what age it has been used with. I know it's been used with children younger than teenage, preteen children.
I believe if we look at this technology as a tool, as you mentioned earlier, we need to use this tool in our therapy, the therapy that we are trained to use in the clinic. We don't need to imagine or try something new. How we used to intervene with the beneficiaries, use it the same way.
Exactly. Exactly. This is simply a tool. You are the therapist. You do the treatment, and it helps you instead of having them imagine or write, where you maybe there, you know, we talked about the disadvantages of that, or saying to them, all right, now go out and do it yourself alone without the therapist help, where you don't control what's going to happen. This allows you to help them have the experience that will be most satisfactory, most helpful, most therapeutic, which is what the gift is. There was a question, Fatima had a question. Oh, is this a remote session of a real client? Okay. So in that simulated video that you saw, the client was using their phone. They downloaded the app and the app was displaying, but I controlled through the internet, through the website. I signed on to the website. I then connected to her phone and controlled what displayed on the phone. Did that answer that question, Fatima?
Yes, I believe so, doctor.
All right. Now, how is this beneficial for hallucinations? This is really interesting work by Daniel Freeman, Dr. Daniel Freeman, psychologist at Oxford University in the UK. He took he took patients with schizophrenia who had auditory hallucinations that were critical of themselves and saying terrible things. And he created an avatar that then said those things, voiced those auditory hallucinations, the same thing that the people are hearing as auditory hallucinations. He then prompted the beneficiary to talk back to the avatar that was saying the things the hallucination said and to dispute them. No, that's not true. That's not right. I'm a good person. You leave me alone. I don't believe you. And what happened was that they became more able to dispute and not be distressed by their auditory hallucinations, and the instance of hallucinations even dropped down. This is cutting edge, fascinating research. And if you work with this population, I encourage you to take a look at his research. And it may be that, again, you can take a virtual environment that's designed for one thing and you can use it for another. Okay, so let me tell you what I mean by that. If, for example, you have a VR video where you are in a social situation with people around you, and there are recorded things that they have said, but if you can mute the auditory part of the VR, you can use it. And when the other person is talking, you can voice what the auditory hallucination said, and you can have your patient dispute it and speak back to it. For, you know, if a person is, let's say a person has claustrophobia, but all you have is a virtual reality of being on a plane designed for flying phobia, you might still be able to use it for claustrophobia because it's an enclosed space. So when you look at a virtual environment, look at the actual content. Don't just look at the label of what it was designed for. Think about, how can I use this content to help my beneficiary achieve his or her goal? So we have answered the question of we can use it with children. What other questions do we have? We have 10 minutes. Let's open it up. You can either put your question in the chat, or you could raise your hand and Fuad will have you unmute yourself. Questions, comments, reactions, concerns? Oh, what are some of the biometrics that you can measure? You can measure, there is a way to measure breathing. You put a measurement around the chest, and you can measure speed and perhaps depth of inhalation and exhalation. If you have a galvanic skin response, you can tape that to one finger and measure galvanic skin response, which is a measure of both tension and just general sympathetic nervous system arousal. However, if you use galvanic skin response, you do want to have a few minutes to have everything calm down and get a baseline. And you have to be aware that there can be artifacts, particularly in situations where they're moving their hands. You're not going to be able to use it. Let's say they're pretending that they're driving a car. You're going to get what are called artifactual readings, ineffective, things that don't actually reflect, readings that reflect movement, not actual physiological response. How much does it cost in general? That is always the question that is asked. It's a very valid question, and I truly, in this situation, I absolutely cannot answer it because so much is not available in Lebanon. Fuad, perhaps you have a better answer to this.
It depends on the hardware that they want to use and depend on the software because of many limitations. Some cheaper applications or softwares aren't available. On the contrary, maybe expensive ones are available. Anyone who have questions regarding these applications or hardwares, I will be happy to answer regarding Lebanon.
Yes, Fuad will be the best resource for what is available to you in Lebanon. I hope that what you can get from this webinar is a sense that this is a research-supported and evidence-based tool for exposure, get a sense of how it can be used, and address some of your concerns or questions about, is it safe? Can it be used for an entire session? Can it be used with children? does it work? Do your beneficiaries, will they accept it? Thor, do you have any comments about the acceptability of either exposure therapy or VR in terms of your Lebanese beneficiaries?
It's always something interesting to expose beneficiaries to this new technology in the clinic. They always will be excited. The excitements mainly overcome the avoidance people or beneficiaries will show when we're talking about anxiety, fear, or traumas regarding these disorders. They will be excited. Yes, what does this happen? And as we can start with showing them neutral environments and relaxation techniques using the VR, they will be more and more ready to face some triggering situations regarding their disorders.
That is a perfectly beautiful summary. Yes,
Yes,
there.
and we are benefiting also as a psychologist from the media that these huge companies are doing for this technology. So, oh, I see this. No, I know this headset. I always want to try it. No, let me try it. Let me see what I can do there. So for that, we will have patients or beneficiaries are ready to use this technique.
Oh, and if any of you treat obsessive compulsive disorder, Andrew Kolsky, Colsky, specializes in obsessive disorder, and he is working to create a group of virtual environments specifically designed for use in treating OCD. And I know that he is eager to share this and to share this information. If you wish to contact him, I can give you his contact information, and he may be able to make this available when it is ready. I know he's still working on it, but he may be able to make this available at a low cost. So, oh, let me type this in the chat. He has a very long email. So it's A. Kolsky, his letter of his first name and his last name. But what makes it long is it's Center for Professional Counseling. Come on.
I will try to contact him and see if he can share some of his
I believe it's
research or
.com.
expertise.
Yes, good, excellent. And I know that the researchers who study PTSD, so that would be Doctors Rizzo, Rothbaum.
Yes, I talked to Dr. Rizzo also. I wish I can manage someday a talk with him.
He is
Maybe a webinar.
wonderful.
He can share with us his knowledge also.
He is fabulous. Absolutely, absolutely fabulous. And if you
Yes.
start to offer VR, all right, please go and get on this website, VR Therapists International, run by Dr. Howard Gurr.
I believe I'm on it.
Good.
It was very nice webinar, Doctor. Thank you for the valuable information you shared for us and answering all our questions and highlighting the importance of this tool to be used in our practice. But I encourage everyone who is ready to use it to use it. He will get awesome results with his beneficiaries. And I wish I will be always available for anyone to help him and guide him as I can with my little knowledge. And I wish we can share in the future more webinars with you or training with you to be deepen in this type of intervention also.
Well, listen to Fawad. Everything he has said is absolutely on target. I think he will be a marvelous resource. I can see that your beneficiaries are benefiting from working with you and working with VR. And I am honored to have been presented. Thank you for giving your time to me and your attention. And I will turn you over with a great deal of confidence to Fouad as your local expert. Thank you
Thank you.
so very much. Have a wonderful
Thank you.
evening.
Thank you, doctor. Thank you.
All right.
Bye.
Bye.